Charlie, can you tell me a little bit about how you got into gynecologic surgery?
Well, not the path that a lot of urogynecologists did, because basically I decided on OB/GYN when I was a third year medical student. It was the first rotation my third year. I had a fantastic experience just shadowing a third year resident named Bob Barmeyer, and he was my inspiration. I just loved the way he interacted with patients. I loved everything he did, and I loved taking care of all these patients in OB/GYN. So that was my first decision, OB/GYN. And then I actually, after residency, I was a generalist for 10 years before I did my fellowship. And during that time, I did a lot of obstetrics, but I really had a passion for GYN surgery. I realized you don't really need an MD degree to do prenatal care. And I was always more interested in the surgical aspects of it. So then I did a preceptorship 1 year out with Don Ostergaard for a month up in Long Beach. And then 10 years later, I did a fellowship with Stuart Stanton in London in 97. And I just always loved urogynecology because it was really improving the quality of life for a lot of women. And that made it just very, very enjoyable. You had really tangible results, 6 weeks after surgery when you saw the patient's back. As an aside, people talk about, having your nurse practitioner, your APP do the post-op visits and everything. And for whatever reason, I never really thought I liked that, but I couldn't vocalize what I didn't like about it until Pat Culligan at his OGS address said that post-op visits are good for the soul. And I realized that is the reason I want to keep doing post-op visits, because those visits are just so good for the soul.
Well, it's interesting that you say that. I can't agree with you more. The other thing, it's validating in terms of what we do, right? Patients like seeing us in particular, mostly because they have gratitude and they'd like to express that to us. In the events that they need something else, they can speak to us directly about it. But the other thing that Mark Walters always told me, and he always did his own post-op visits too, within a practice where no one else was doing them. He would always say, how do we get better? Right? How do we actually sort of start making decisions for route or approach if we don't know what happens to that anterior wall after native tissue, and actually ask patients if it's bothering them, et cetera. And so I think there's something to be said about seeing your own patients.
Absolutely. Absolutely.
You've mentioned quite the lineup. Any other mentors or sponsors that you've had along the years?
Well, all the people in the UITN and the PFDN for the last, since 2000 have been my mentors. I've learned so much being involved in those networks, from all the discussions we had, designing trials and talking about practices and everything. And really, I just owe so much thanks to all those early UITN and
in your mind opinion, what makes a good gynecologic surgeon?
Good question. First of all, I think you have to be a good doctor. That's the prerequisite. You have to have all the qualities of being a good doctor. After that, you really have to have a passion for trying to do the very best for your patients in the operating room. And I think what makes a good surgeon is, you have to have a baseline amount of hand-eye coordination, but I've seen people who weren't naturally gifted, but through hard work and perseverance became good surgeons. So I don't think I think you can become good, but it's mostly attentiveness, attention to detail, to be a good surgeon. I think too many learners think that if they're not operating, they're getting nothing out of it, and they just check out of a case. And that's not right. You need to be involved in the case and watch and learn, even if you're not actually, being the monkey on the procedure. You just have to pay attention. So it's attentiveness, attention to detail, lifelong learning, and adaptability. There's very few things that I do now than I did 20 years ago. It's a constant evolving field, and you have to be ready to adapt and evolve and question things you do. I think it's really interesting. I mean, some of the things I think we learned how to do, anterior repairs and plicating this worthless tissue underneath the bladder, are really pretty worthless. You have to think about, what are you really trying to put together?
That's a great answer. So the upcoming theme for the SGS meeting this year in March is surgeons as change agents. That's the theme that's been chosen. What does that mean to you, and what changes have you really sort of watched over your career, and what do you think is in the pipeline?
Oh, almost everything's changed. As a resident, I started doing needle bladder neck suspension procedures. They were taught by one of a very old faculty member here named Raphael Durfee in our faculty. And then after the preceptorship with Ostergaard, where we learned slings, and then learned, birches, and working with Stanton, doing birches and sacrocolpoplexies, all of that was different than training. So everything has changed over time. The mid-urethral sling revolutionized stress incontinence surgery, and it's so much better than anything we have. And that was such a major advance. So be ready to adapt to change as long as there's evidence. I think that's the main point. Make sure there's evidence. Don't just change for change's sake, because there were a lot of bad designs and innovations in early slings and early prolapse kits that people adopted, because they were marketed and not because of any evidence. So be careful. But what I would tell everyone is just make sure there's evidence for it. In the future, I think it's very, very promising. I suspect we will have very delayed absorbable mid-urethral slings made out of material that may last for a year but gradually dissolve. So there's no long-term mesh complications, but you've got this matrix of scar tissue that's going to give you support. I think we'll probably see that, and that'll eliminate any concerns about long-term mesh. I think we'll have better pessaries. I think there's a lot of role for improving the whole conservative management. And we've got better tools so that we can do things minimally invasively. I've converted a lot of my vaginal hysterectomies to using electrosurgical energy, just because I think it's faster, safer, and I'm less likely to get a hematoma down the road from a pedicle. So I think for a long time, vaginal surgeons insisted on clamp cut and suture ligate, and we were being left behind by the technology that was being introduced with electrosurgical procedures, and we can use those vaginally. There's nothing magical about having to put it in the abdomen to do that.
Shifting gears a little to talking about SGS specifically, what keeps you going to meetings? Whether it's each year or every few years, what keeps you attending the SGS meetings?
Yeah. So what I love about SGS is the networking. It's a smaller meeting. It's a lot easier to talk to your colleagues. I like the format where there's a discussion of the papers. I always like doing that, and I always like listening to that. I thought that was really a lot of fun. But it was hearing about the latest surgical procedures, the way people are doing it, but mostly just talking to people. The networks are just invaluable in SGS, and because it's a smaller meeting, it has those advantages over things like HOGS.
So it's not a huge secret that you're nearing retirement. What is retirement going to look like for somebody who's dedicated a massive component of their time to gynecologic surgery and innovating our field?
Well, fortunately, I've had a way to transition to this by working, part-time for the last 5 years since I stepped down as chair, and with essentially a week on and a week off kind of a schedule. And as it's gone on, I initially enjoyed my weeks of work just as much as I enjoyed my weeks off. Now I find I enjoy my weeks off more than anything. So that's the time to step down. And it's gonna be tough. I'm gonna miss colleagues. I'm gonna miss friends. I'm gonna miss the youth in the hospital, the intellectual stimulation. But I hope to read and stay up to date as much as possible. And my wife's been retired for 10 years, so she's been more than ready for me to join her in this venture, in this new trip.
You can still attend journal clubs.
I still can attend journal club, and I very likely will.
I think everybody would be very happy if you did that, including myself.
Well, sometimes a little history is helpful for things. It's amazing how many things come back around. Even when I was at OG's meeting just this year, I realized some of the things that we discussed, we had heard about 10 years ago, and people should really just look back at what's been written already.
That's true. I did this with John Delancey a few days ago, and we were talking. He actually then actually spent a while pulling all of these articles and then sending them to me. But we were talking about where we've come from, right? And not forgetting the historical articles that exist. Because honestly, actually, I was looking through a few of them, and I have them from Mark's archive too. He had made me, because I like history a lot, and so he had made me this file. And some of those articles, I mean, there's nothing better than them. The anatomy that they describe, the pictures that they include. And so I was thinking we should actually do that for one of our sessions too. Our fellows are so unaware of some of these things. But one of my favorite questions, because it's always fun to find out what people's answers are, is tell us what your favorite instrument is for gynecologic surgery and why.
Well, it would have to be the Bresky Navratil retractor, because with it, you can do uterosacral suspensions and really see the ligament well. And, with two good Bresky Navratil retractors and two good assistants, I don't think you ever need V notes. But not everyone has two good assistants all the time. So I understand why there is V notes there. But that instrument allows you to just help you see everything so well. And so since most of the stuff I do is vaginal, I'd have to pick a vaginal instrument like that.
I think you're in good company. The Bresky has been a lot of people's favorite.
Oh, really? Okay.
Yes. Holly Richter's favorite instrument is the Alice clamp. Because I would say it's because we use a lot of them. But yeah, no, you're in good company with the vaginal surgeons for Bresky. I think that makes a lot of sense.